Well, thank you, Dr. Iserson, for meeting with me. It's a pleasure to have you. I would love to get a little introduction from you.
Okay, well, it's nice to be here talking with you. I'm Ken Iserson. I've been in the medical field, the emergency medical field, mostly for 50 years. I started before there were EMTs in the United States, went on to become an academic emergency physician, researcher, writer, trauma center, and then went into international medicine and have worked or taught on all 7 continents, including a year and a half in Antarctica.
Oh, wow, that's really impressive. That seems like an incredible experience and journey that you've had.
It's almost like I knew something was coming and I better get it all done.
Yeah. Oh, that's amazing. And I'm curious, before you received your own diagnosis of normal pressure hydrocephalus, how familiar were you with it during your years practicing emergency medicine?
Well, I have to tell you that I, thinking back, I don't remember diagnosing one case, uh, and actually rarely seeing any uh, patients with shunts. Uh, I assume the pediatric patients would have gone to their neurosurgeon. I remember seeing a few, but not very many. And that diagnosis did not cross my mind almost ever.
Oh, well, that's interesting to hear. We do know from some of our own data that the emergency room is one of the first contact points when people are experiencing an emergency. So the fact that you've been an ER physician for this many years and haven't really had experience with hydrocephalus patients is really informative for us. Thanks for sharing that.
Sure. And one of the things I'm doing to help remedy that is I have 7 or 8 publications out for review right now, uh, trying to get my colleagues to do the very basic workup to try to diagnose what's called possible hydrocephalus, and then referring them on to a neurologist.
Well, that's incredible. It's amazing to hear that you're working on those publications. And we know education is so important, not only to the community, but also to other physicians and doctors who might potentially be treating this. So thank you for that.
Well, we'll see if it works.
Yeah, it'll be more literature out there for people to be educated though. So that is extremely important. And let's take a step back a little bit. And if you had to explain what normal pressure hydrocephalus is, how would you explain it in plain language and some of the classic symptoms surrounding it?
Well, we really don't know what causes it. But what we do know is the brain normally kind of floats in cerebral spinal fluid, clear, almost like water, it looks like. And for some reason, too much is inside the brain and doesn't flow out like it's normally supposed to. It progressively increases the size of what's called ventricles or holes inside the brain, and that causes all the different symptoms, the multitude of symptoms that NPH patients suffer from. And it's gradual. It's a very gradual process. So unlike a stroke or a heart attack or something else, it may be hard to initially recognize.
Yeah. And for your own personal journey, what were the first symptoms that you remember being able to recognize?
Samantha, in truth, I have to do this retrospectively.
Mhm.
What improved finally after the VP shunt that I have in place? So the first thing I noticed was a tremor that was on one side that was passed off as a familial tremor. My father also had it. And my brothers rightfully asked, did he have what I have? Nobody knew. And they didn't explore that, which is unfortunate. So I had the tremor, and I had that for a number of years, and it didn't really interfere much with what was going on. Then I started getting rather severe back pains. That's not supposed to go along with NPH, although it cleared up immediately after I got my shunt. I mean, pretty dramatic. And when my shunt failed at one point, the pain came back. As soon as it was fixed, it went away again. So I think that was it. The real noticeable change was I was in Antarctica, and suddenly I had a foot drop on one side. I started tripping over my own foot when I was going upstairs. And that was just weird. And I knew the typical differential, and I didn't have it. And then gradually, my gait got worse, my running got worse, then my walking got worse. Uh, I didn't notice changes with my thought pattern. My wife did. Uh, and as far as the urine, which is pretty typical, you either have incontinence or you have urgency. I had a prostate problem. And so that hid the urine situation. So it was pretty complex, and I was worked up for initially for Parkinson's disease. The neurologist right off the bat said you don't have it, but she still ran a couple tests to find out, and she was right. Uh, there was a very experienced neurologist who was called in, and he worked me up for diseases I'd never even heard of that were autoimmune, and no, nothing came up. And then I went on my own to a place that is known as a special center for uh, NPH, because that's what I believed I had. Everybody else thought no, almost everybody. I'll get to that. And a supposed expert neurologist came in and says, "Oh, you don't have NPH. You're going to die from this other Parkinson's plus disease. Go home." Uh, that wasn't very good. There was one neurologist who agreed, yes, you have NPH. And this was a lady who I was sent to for a electro neuro test. And she went through the whole thing and says, you have NPH. Why isn't anybody doing something? I said, thank you. She was very nice. She's since gone on to a very nice practice, and practice is actually next door to my neurosurgeon.
Oh,
So, but it was a long, complex, multi-year event. And if I had not been a physician, I would have been left out in the wilderness. I just kept pushing and pushing and pushing. In my city, apparently there is nobody who does the high volume tap. There is nobody who does the physical therapist evaluation. So I had to go out of town for that. Uh, yeah, it was a long, extensive journey.
yeah. We hear that from so many other patients as well, that they get misdiagnosed for Parkinson's or Alzheimer's. And it's incredible that you have your physician background, your medical degree, and you were able to look up and actually pretty much self-diagnose yourself. But the fact that you went to neurologists and were still having trouble getting the diagnosis, even though you handed it to them, is really telling of just the more education that is needed surrounding normal pressure hydrocephalus, and then also better access to care throughout the country. There are
Oh,
certain,
absolutely, absolutely,
yeah, there's
absolutely.
certain hubs, but especially other places where there's really not a specialist there, we definitely need to have that.
Doctor shopping, which as an emergency physician, it used to drive me crazy with patients. But I ended up at the fourth neurosurgeon. I never actually saw the first three. One never, said they were going to call and they never did. Another one, well, anyway, the way I got to my neurosurgeon was I was having breakfast with a friend of mine who's a retired infectious disease doc. And he says, "Have you called?" And I said, "No." He says, "Well, I worked with him for years and he does this surgery and he's very good at it." I said, "Okay." So I called him up, got an appointment relatively quickly. I went in. My wife and I learned that we better go in together. And so we went in and we were expecting the runaround like we had had. And I had given him all the papers I had. And we sat down and he said, "Well, when would you want the surgery?" And I said, "This afternoon." And he just smiled. And this was on a Friday. He said, "How about Tuesday?"
Wow, that's
And I was
interesting.
in. That was it. But it was pure luck. I mean, I was at breakfast and a friend referred me.
Yeah. So were you having difficulty getting a referral once you got the diagnosis of NPH from the neurologist?
Uh, it wasn't so much that I was having trouble getting the referral. Uh, First of all, it was a long, long wait
Mm.
to get in to see the neurosurgeon.
Okay.
A neurosurgeon. I had a neurosurgeon for another problem, and he suddenly died in an accident, and so.
Okay.
But he didn't do the surgery either. Almost nobody in my city does it, which is really strange. But I think it may be because the neurosurgeons are often the ones who have to do the follow-up, and that's not their typical mode of practice.
Mm.
But luckily, I found one who does.
Yeah. And then have you gone back to the neurologist at all for a follow-up, or was your follow-up solely with the neurosurgeon?
Absolutely not. Just with a neurosurgeon, he's very responsive. Uh, I had some, I've had every difficulty you could possibly have post-op, and not his fault. Uh, I had actually what could be a reportable reaction to after the surgery. Uh, I'm sorry about that. We get all kinds of strange calls.
No worries, I get it.
Okay. Um, Strange reaction. Uh, and it was to the wound glues they use,
Okay.
the super glue or whatever. And probably because of all the years that I had been using it. And I had that, it led to an infection. So I had that and an infection, they had to take it out. Okay.
Okay.
So that was part of it. I had it put in again on the other side. All right, I was doing pretty well. Eventually, it got back down to the setting where it had been, and my symptoms started coming back. So, what was it? It had spontaneously changed the setting. I hadn't had an MRI, and I've just done some research on that. And it sounds like it may have been the earbuds for sleep that I use. My wife is a snorer. And so I use those. And what I found out is the FDA recommends that you keep those kind of things 2 inches away, at least 2 inches away from the shunt. And this isn't 2 inches away from the shunt. It
Yeah.
was here. And anyway, so he was, he responded right away and readjusted it.
Mhm.
And I had had sudden loss of hearing in that ear and tinnitus, loud ringing.
Mhm.
And so I had seen an ENT, and the ENT says, "Your shunt's not working." And the neurosurgeon, as he's right to do, said, sure, yeah, we hear this a lot. But he was surprised. He interrogated it, and it had changed significantly. Two stops from a 3 to a 5. So he put it back to a 3. I'm doing really well, and I'm not using the sleep bud.
Um, Hopefully you're still getting some sleep though.
Oh yeah, I'm using the
Okay,
wax sleep.
that's good.
They're
Wow.
they're pretty good.
Yeah.
Yeah. And everything is going well, and I'm doing a lot of my writing work because I'm also a writer. I have lots of books and other things, and yeah.
Incredible. And it's amazing that you were able to discover that it was the earbuds too that were causing the changes in your shunt. I hadn't heard that before, but that's informative.
Well, I'm an emergency physician, and our job, we're shown as being, sticking the needle in here and the knife in there. And one of our real big jobs is as a medical detective. Why are things going wrong? And I figured it out, and I found the FDA site that talked about it, and yeah, and it just makes sense.
Yeah.
And I should say the Oslo sleep bud people were very responsive, and they're looking into the magnetic fields, and
Oh, great.
you may be hearing from them if they have a warning to put out.
Okay. Yeah,
Yeah,
that's incredible. And I think something valuable to share with our community too, of just, hey, we don't know for sure, but be aware that this is something that could have an effect on a programmable shunt.
right. And right, the FDA says earphones, cell phones, other things with relatively strong magnets, keep
Yeah.
them 2 inches away
Okay.
from your programmable shunt. Use it in the other ear, for example.
Yeah, that's
Yeah.
really great insight. Thank you. And I kind of want to shift to a little bit more of your perspective in the emergency room. From an emergency medical standpoint, what do you think are some of the reasons why normal pressure hydrocephalus is frequently missed, especially when patients or older adults are coming to the ER with symptoms like falls or trouble walking or confusion?
Okay. We say if you hear hoofbeats, don't think zebras, think horses. And as far as we know, and this may change, but most of the patients who come in with hip fractures, with urinary symptoms, and then geriatric is often sepsis. Uh, these are going to be caused by just routine non-NPH
Right.
reasons, or perhaps even another neurodegenerative disease. So we're not really focused on that. We're also have to be, because of the nature of our work, focused on the diagnosis and the treatment, the immediate treatment. Uh, if they have a urine infection and they're geriatric, they may have sepsis, they need the antibiotics, they need the labs, they need all of that. If they have a hip fracture, okay. So that's really one of the reasons. But there are the people who come in with the history, that they've fallen, they don't have the hip fracture. Their gait could be easily tested. It takes a couple of minutes. It means getting them off the bed. We don't do that very often. Uh, and testing their gait, which is very simple because you're really only testing speed in the emergency department. Physical therapists and neurologists will test other things, but for our purposes, just the speed. Uh, and then the history from the caregiver or the person. Uh, and then, if it's indicated, get a non-contrast CT scan, which is readily accessible to us. So if those are all positive, you send them off to a neurologist who then does the evaluation. but we're not taught anywhere to think NPH as a possible cause.
Right.
So that's what these publications that I have out there are hopefully going to change the attitude, and
Yeah.
people will at least ask the question.
Definitely. And maybe you can share a little bit about what are some of the suggestions in your publication on having better NPH diagnosis in the ER, or just being more aware of some of the symptoms to look out for.
If the relative says mom's gait or mom's walking is now shuffling, okay, or she's hesitant, or she's scared, or turning around is, well, in block, but is very slow, that's one of the big issues. And then she's having problems with her urine. She has to wear a pad. Now, that's not uncommon, but still, that goes along with it. And she's not as sharp as she used to be. So the easy thing is just pass it off. She's getting old. That's just getting old. But age is really uh, a reason that people get disease. It's not the disease itself. And so we have to think of that as what we call an etiology or a cause for this. And then you do the simple tests I mean, very simple for us. You do the gait, you have the history, you do this head CT. If the head CT, we're not going to be probably diagnosing, excuse me, NPH ourselves on head CT, but the radiologist should be able to easily, because there are some easy tests they can do. Or when we get to AI doing all our CT readings, that'll say, think NPH.
Yeah, and we have a lot of researchers actually working on that of creating better tests with imaging and then incorporating AI as well. So hopefully that will help improve MPH diagnosis. But I like what you said, and it's kind of that classic triad of symptoms, which is gait problems, urinary incontinence, and then cognitive decline. And hopefully just having those publications out there and having more awareness to the ERs and different physicians that will help allow people to get a better diagnosis.
I hope so. But again, for anybody who's listening to this, they can have other symptoms. It's not limited to that, but those are the three that were classically described and people should look for.
Yeah. Yeah, and based on your own experience, and then of course your experience as an ER physician, what advice might you have for people that suspect that they have normal pressure hydrocephalus, and ensuring that whichever doctor they're seeing is taking them seriously and doing the proper evaluations?
Well, outside the ER, uh, they go to the physician and they can say, I think I have NPH. And most likely the physician will say, huh, what? And so they'll have to explain it. They'll have to be able to give them a publication that explains it, and they can get it off the hydrocephalus site, association site. Or they can explain it themselves and say why they think they have it, and that they want to be referred to a neurologist. I would say someone who specializes in NPH, but I went to one and they were so off the mark that, anyway, uh, yeah, you want to go to a neurologist who'll listen to you. They may order additional tests, especially an MRI, and then being referred to a neurosurgeon who does some type of shunt. And it doesn't have to be a ventriculoperitoneal shunt. There's other shunts that people are doing, ventricular atrial, ventricular pleural. putting it in the lung cavity. That's not very common. And certainly outside the United States, they do lumbar surgery of the lumbar area. And that seems to be, all of them seem to be pretty effective.
That's great advice to give to people. And thank you for plugging the Hydrocephalus Association website too. And yes, for
Well,
anybody who's
it's
listening to this, we do have incredible resources on that and many pages focused on normal pressure hydrocephalus, even some pages focused on what's the difference between NPH versus Alzheimer's disease versus Parkinson's disease. And you can really look side by side on what some of those differences are. And hopefully that can help with a better diagnosis too, particularly for those that are being misdiagnosed.
absolutely.
Yeah,
I even mentioned them in some of my papers, the
perfect.
association.
Great, thank you. And we're very excited to see your publications as well, and just really grateful for the advocacy and work that you're doing to ensure there's better education. So, kind of in closing, I want to know a little bit more of how has your daily life changed now since you've gotten not only your diagnosis, but your shunt treatment?
Well, let's say hopefully my final shunt treatment, where I got my second shunt and it's been readjusted, and I'm hopefully not going to have large changes anymore. My writing is picked up. I had to stop practicing medicine because of all the symptoms. Uh, for a while, I stopped driving altogether, but now that I'm really feeling better, that's coming back. Uh, I can't use the earbuds.
Yeah,
That's a big deal. But
Mhm.
but otherwise, see, if you can see my desk, you'd see how much work I'm doing. It's 5 piles of papers of things that I'm working on.
That's
Uh,
amazing.
but you know, I spent 50 years in clinical medicine, pre-hospital care, emergency department, search and rescue for 25 years, international, and unfortunately, I just had to uh, give that up. But hopefully, I'm contributing. I'm still contributing, uh,
Yeah,
but I feel good.
that's good. I'm
You
really
know,
glad to hear that.
yeah. Thank you.
Yeah. And then I know multiple times you've mentioned the importance of a caregiver, in your case, your wife having recognized some of the symptoms. Is there any advice you would share with caregivers that are supporting somebody going through the diagnosis or treatment phase?
Be tolerant of the patient. Be tolerant of your own limitations, and figure out how you can get some respite, because that is a terrible job, to have to be a caregiver. And it just depends on the level. In my wife's case, it's diminished as I'm getting better. But you just have to be aware of that. You need to seek out community or family resources to give yourself some respite in all of this.
Yeah. Yeah, that's so important. And a big thank you to all the caregivers out there that are doing all of this behind the scenes work. I know a lot of times our conversations are focused on the patients, but the caregivers play such a huge role in both the diagnosis and treatment and care. So, yeah, it's incredible what they do. All right. So, last thing in closing, do you have any additional advice to people who suspect normal pressure hydrocephalus, either in themselves or their loved ones?
This isn't talked about very much, but don't let the depression of the naysayers who are telling you you don't have it or it's all in your head, which it is, uh, get you down. Keep advocating for yourself. You have to keep advocating for yourself, because if you don't, you're going to be left on the wayside, end up in a nursing home, and all bets are off. You just have to keep fighting.
Thank you for that advice. That is so important to have people keep advocating for themselves and definitely seek the various resources that are out there, whether it's educational information, the support groups. There's so many people that are going through a very similar struggle with getting diagnosed or getting their treatment. And we have support groups at the Hydrocephalus Association. So even if somebody suspects that they have normal pressure hydrocephalus, whether they truly do or do not, these communities are open and we want to facilitate those conversations to ensure people truly get the proper diagnosis. So thank you so much for meeting with me and sharing all of your insights. This is so informative and extremely helpful to share with our community, so people can see, the experiences that each person is having.
Well, it's been a pleasure talking to you.
Thank you so much.